From the JAMA Network, this is JAMA Internal Medicine Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Internal Medicine.
Hello and welcome. This is Dr. Eve Rittenberg, the Viewpoint and online editor at JAMA Internal Medicine. Today we're talking about a strategy to increase access to medication abortion. We'll look at a study that provided mifepristone by mail rather than during an in-person visit or from a brick-and-mortar pharmacy. And this is a really important topic because since the Supreme Court Dobbs decision in 2022, it's become increasingly difficult for people in many parts of our country to access clinics that provide abortion care. And so more people are seeking medication abortions. So safely and effectively lowering the hurdles to providing mifepristone is crucial for providing equitable and accessible reproductive health care. So that's why we're talking today with Dr. Daniel Grossman. He's the first author of a study entitled Mail Order Pharmacy Dispensing of Mifepristone for Medication Abortion After In-Person Screening. His study examined the feasibility, acceptability, safety, and effectiveness of mail order mifepristone. Dr. Grossman is a professor and the Vice Chair of Advocacy for the Department of Obstetrics, Gynecology, and Reproductive Sciences at UCSF. And he serves as the Director of Advancing New Standards in Reproductive Health. We're also going to discuss what dispensing mifepristone from a mail order pharmacy can mean for clinical practice, and especially for primary care clinicians. So we'll talk with Dr. Emily Godfrey. She's the author of the commentary, Mail Order Mifepristone and Primary Care's Role in Providing Medication Abortion. Dr. Godfrey is a professor of family medicine and obstetrics and gynecology at the University of Washington in Seattle. So now to our guests, Dr. Daniel Grossman and Dr. Emily Godfrey. So a warm welcome to both of you to the JAMA Internal Medicine podcast.
Thank you so much. I'm so excited to be here.
Thank you, Eve. I'm excited to be here as well.
Dr. Grossman, can you tell us why was it so important to study mail order mifepristone?
So we started this study back in 2020, and at that point, the U.S. Food and Drug Administration had very strict requirements imposed on mifepristone that were codified in what's known as the REMS, the Risk Evaluation and Mitigation Strategy, which required that the drug be dispensed in person at a doctor's office, at a clinic, or a hospital. So it was not possible to mail the medication. It wasn't possible to use a mail order pharmacy. It had to be dispensed in person. And this was a real barrier for some clinicians. We had led a survey back in 2016 or 2017. It was a nationally representative survey of obstetrician gynecologists. We found that overall, about 14% or so of OBGYNs who had seen a patient who needed abortion care in the prior year, about 14% of them said that they provided a medication abortion. But that number actually seemed like it would double if clinicians could, instead of stocking the medication and dispensing it in person, if they could use a pharmacy to dispense the medication. They were much more likely to say that they would provide it. So we were able to get an investigational new drug application approved through the FDA to do a study that kind of went around this requirement that they had of the in-person dispensing requirement to just see how this could work.
So tell us what you found.
The findings are not at all surprising. We did a prospective cohort study, and we enrolled people in 11 clinics across 7 different states. The study was done between January 2020 and May 2022, and we prospectively enrolled people who were evaluated in person, and they were screened for eligibility for medication abortion. And then if they were eligible, they had the mifepristone and other necessary medications prescribed through a mail order pharmacy, which was then usually sent the next day to the patient's home, although sometimes sent to other places. And then we collected clinical information as well as surveys with the patients to get their perspectives on the service. Not surprisingly, we found that the overall effectiveness of the regimen was very high and essentially really identical to what we've seen in other clinical trials. We found that the overall effectiveness of the regimen was about 97.8%, and there was very high acceptability with this service. About 90% of patients said that they would use a mail order dispensing model again if they needed an abortion. About 91% said that they were satisfied with their medication abortion. We found that a little over 85% received the medication within 3 days. And we also collected data on safety of the medication abortion regimen, and again found that the model was very safe. There were 3 serious adverse events. So that was a proportion of about 0.6%, which is similar to what we see in other large studies of medication abortion. So the bottom line is that this really seemed like it was a model that was effective, it was acceptable to patients, and our findings around safety were really very similar to what we see with other studies indicating that this model is safe.
So those are really impressive findings of the safety and effectiveness of this method that decreases some of the barriers for a wider group of people to feel comfortable prescribing medication abortion. And I hear that, I'm a primary care internist, so this really resonates with me. And I'm wondering if we could now turn to Dr. Godfrey for a moment to talk about what you think about the ways in which this study and the idea of being able to prescribe medication abortion through a mail order pharmacy has meaning for broadening medication abortion within primary care.
Thank you, Dr. Rittenberg. And I just want to say I'm thrilled to be here. And regarding your question about Dr. Grossman's study and how it relates to primary care, one thing that's really important to note in his study is that he mentioned that there were 11 clinics, and more than half of these 11 clinics were, in fact, primary care clinics. And there were a handful of primary care providers who had not necessarily been providing medication abortion within their bucket of services before enrolling in this particular study by Dr. Grossman. So I think what's really important to highlight here is that providing medication abortion is not rocket science. It is something that can be easily learned and provided to patients. So just to say that this is very doable, as long as you know how to date a pregnancy, you really do have the skill set to provide medication abortion in a primary care setting.
So interesting. And so, Dr. Grossman, your study design had in-person evaluation and screening first before the mail order prescription. I'm wondering if you can talk a little bit about that choice of design.
I think perhaps where your question might be going is about telehealth provision of medication abortion. There's been tremendous expansion in the use of telehealth in really every area of medicine, and a lot of that was accelerated by the COVID-19 pandemic. And that's certainly true in abortion care as well, and perhaps we can talk more about that. But when we were planning the study back in 2019, we were really focused on a model that we were hearing from primary care providers that they needed. Often, as Dr. Godfrey was saying, providing medication abortion isn't rocket science, and these clinicians wanted to provide this service, but often they faced barriers to getting the mifepristone on site in order to be able to dispense the drug in person as required by the FDA. Some of the reasons why was that sometimes it was just logistically complicated in a large health system to get the mifepristone into the clinic. Sometimes there was opposition from facility leadership that didn't want to be providing abortion care. And so even if there were clinicians in the clinic who wanted to do it, they faced barriers in the clinic system to getting the mifepristone on site. And so this model of working with a mail order pharmacy was a way to get around that. And we were able to get an investigational new drug application approved by the Food and Drug Administration in order to get around this requirement that they had in-person dispensing in the context of this study.
Great. Thank you so much. And do you have some next steps for your work? Are there things that you're excited about looking at in this area for future study?
Certainly, as I mentioned, there's been a real expansion in the use of telehealth. I do think we need some more data that sort of directly compares outcomes with telehealth medication abortion with in-person dispensing models. So that's one area with another study that we're finishing up. Long term, there's a lot of evidence indicating that medication abortion is safe and effective enough that I think that it actually meets the FDA's criteria for over-the-counter sale. I understand that, again, that's sort of a long-term vision, and there's a lot of work that would need to be done to, first of all, demonstrate that through research, but that's certainly one area that we're working on, trying to build up the evidence base for future over-the-counter switch for medication abortion. And of course, the reality is that even in a facility-based medication abortion, much of the process is already completely managed by the patient at home on their own. And with the expansion of self-managed abortion, where people are obtaining these medications outside of a a clinical facility on their own. That's very similar to an over-the-counter environment.
Oh, that's really fascinating and just a huge paradigm shift from the tightly regulated and controlled current environment. So really fascinating. And Emily, could I ask one question? Given the current climate of varying abortion restrictions, what about clinicians who are interested in prescribing medication abortion but may live in states that restrict or outlaw it altogether?
That's a great question. So abortion historically has been restricted, and now that states regulate abortion access, it's even more restricted. And so I think any primary care provider needs to know the laws of their state. And so if abortion is not permissible in the state, primary care can still be supportive of patients who may be facing an unwanted pregnancy, depending on the laws of the state, provide information of where patients can seek care, sometimes through telehealth or leaving the state. But otherwise, in other states, primary care can only point to a website for patients. And I think what's really important to emphasize here is how important it is to have reproductive life planning discussions. If a primary care provider is in a state where abortion is not permissible, and primary care can play a very important role in terms of providing a contraceptive method of the patient's choice.
Emily, I wonder if you have one clinical pearl for people, for our listeners, about what they might do if they're interested in learning more about prescribing medication abortion.
So we do have quite a bit of education around medication abortion. I think one of the great sites to go to is called Innovating Education in Reproductive Health. And I teach medication abortion to our primary care residents, and we have both family medicine and internal medicine who rotate through our clinic. And this is just a great resource in terms of just watching videos, in terms of medication abortion, or learning a little more about the telemedicine no test approach. And we have had internal medicine do other training programs that are available through that website. So I think that is the best website to start with in terms of education around medication abortion.
Great. Well, thank you both so much. This was really terrific. And I know I learned so much from talking with both of you. Thank you both for being here and for your excellent work. So this is Dr. Eve Rittenberg, the Viewpoint and online editor at JAMA Internal Medicine. Hope you enjoyed this JAMA Internal Medicine podcast. This episode was produced by Shelley Steffens at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. And thanks for listening.